large-scale observational research over the last couple of years. Welcome, everybody.
Thank you, Mark. So good morning, everyone. I would like to welcome everyone to the first plenary session of the day. I will have the pleasure to introduce the concept of the LEGEND initiative, and in the next hour, oh, I'm sorry. Yeah, sure. How do I?
Just go. The slides are projecting.
Oh, sure. Okay.
I'll let you know when they're projected.
Okay, sounds good. Thank you. We will hear in the next hour some insights on the clinical results from the LEGEND type 2 diabetes. So my name is Aline Pedroso. I am an associate research scientist and the lead for scientific operations of the Cardiovascular Data Science Lab. My slides are not showing, but we can improvise. It's okay. So we have a wealth of observational data available from healthcare systems, and including administrative claims and also electronic health records. And we can leverage this data to fill evidence gaps in medical research. And even though there's a wealth of evidence from this data, it's hard to make causal inferences from this data due to some common limitations for observational research, including some confounding and also p-hacking and also publication bias. Okay, sounds good. Oh. Okay. How do I go back? Okay, perfect. So, okay. So in face of these challenges, some members of the Odyssey community came up with the LEGEND initiative to generate some evidence from healthcare databases and answer these knowledge gaps while addressing some of these limitations. So the biggest effort, I'm sorry, I'm not getting the right slides. It's okay. So the first major effort in this domain was the LEGEND hypertension study that included some sorts of large-scale studies on the comparative effectiveness of antihypertensive drugs. And in this context, the LEGEND diabetes has an even larger scope and includes some major multinational studies on the utilization and the comparative effectiveness and safety of these new cardioprotective antidiabetic agents to fill some knowledge gaps in diabetes care. So some of these knowledge gaps include the fact that the clinical trials of these drugs did not include a head-to-head comparison of these drugs with older agents. So we don't have an idea of the effectiveness of these new cardioprotective drugs compared to some older agents. Secondly, there are also not evidence on differences within different drugs inside the same classes and different drugs in different classes. Another knowledge gap is that these trials, they were designed to compare the cardiovascular efficacy and safety of these agents for cardiovascular outcomes, and they were not powered to test for non-cardiovascular outcomes. And finally, another knowledge gap is that there were limitations in enrollment for these trials in terms of region and also subgroups of age, sex, and race. And this limits our ability to make inferences for different patient populations. So before we even started addressing these knowledge gaps, we studied the national landscape of these studies, including 9 countries, 18 administrative databases nationally and internationally, and including 18 million patients. So first, we studied the proportional use of second-line agents. In these plots, you can see that each bar represents the proportional use of 4 different second-line agents among the second-line agent users. And each bar represents a different national database. And we can see that the red and the blue combined they represent the cardioprotective agent use. And we can see that in these 5 national databases, around 40 to 50% of second-line users initiated the treatment with a cardioprotective agent. And these patterns of use, they were different for healthcare systems. For example, we can see that in the VA, there is a very small percentage of use of GLP-1s. And this difference was even bigger for international databases, where the use of second-line agents was largely represented by the use of SGLT inhibitors. Sorry, I don't have the right slides. Also, we investigated the increase in utilization in uptake of these agents between 2015 and 2021, and we could see that there was an increase in the use of these agents, but this increase was not selective, meaning that patients with and without CVD started using these agents, and there was no significant difference in use between patients with and without CVD for 7 out of 17 databases. In some of these databases, the use in patients without cardiovascular disease was even higher than for patients with cardiovascular disease. I would like to thank you, the Odyssey community, for the LEGEND initiative. And in the next hour, we will have some discussions on the results of some of the LEGEND diabetes studies, including the comparative effectiveness of the second-line agents, also the effectiveness of these agents when used as first-line agents, and some comparative safety of these agents as, for non-cardiovascular outcomes. I would like to invite Dr. Arya Aminorroaya, who will be presenting on the comparative effectiveness of second-line agents. Dr. Aminorroaya is a postdoctoral fellow at the Cardiovascular Data Science Lab and the LEGEND team from Yale School of Medicine.
Thank you, Aline, and good morning, everyone. It's a pleasure to be here. After the nice introduction laid out by Aline, I will be talking about the comparative cardiovascular effectiveness of second-line antihyperglycemic agents in the LEGEND-T2DM network. So let's start with the clinical challenge. We have patients with type 2 diabetes and established cardiovascular disease who are on metformin therapy, but they still have high blood sugars. So we have to start them on a second-line agent, and we have 4 different options: SGLT2 inhibitors, GLP-1 receptor agonists, DPP-4 inhibitors, and sulfonylureas. Since these patients have cardiovascular disease, so we do care about the cardiovascular effectiveness of these agents. And the existing evidence in cardiovascular outcome trials have shown that compared with placebo, SGLT2 inhibitors and GLP-1 receptor agonists, they reduce the risk of myocardial infarction, heart failure, and death. But the DPP-4 inhibitors have neutral cardiovascular effects, and we don't know much about sulfonylureas. The knowledge gap is that we actually don't know the comparative cardiovascular effectiveness of these agents relative to each other. So we don't know which one of these agents should be prioritized as a second-line agent in these patients. To address that challenge, we leveraged the potential of the LEGEND-T2DM network. We included of more than 4.7 million patients with type 2 diabetes from 18 real-world data sources, including claims databases and electronic health records, all of them mapped to the OMAP common data model. Since we are dealing with observational data sources, we adopted a target trial emulation design. So we looked at patients with type 2 diabetes and established cardiovascular disease who were on metformin therapy for at least 3 months and who initiated a second-line agent without no prior events. For the exposure definition, we used the new user cohort definition. So we had 4 different cohorts: SGLT2 inhibitor initiators, GLP-1 receptor agonist initiators, DPP-4 inhibitor initiators, and sulfonylurea initiators. And with these 4 agents, we looked at 6 different target comparator pairs, and we looked at 2 different outcomes: 3-point MACE, major adverse cardiovascular events, and 4-point MACE, where the 3-point MACE included acute myocardial infarction, stroke, and sudden cardiac death. And 4-point MACE additionally included hospitalization for heart failure as well. For the analysis, we adopted an on-treatment analysis where we excluded the information for patients when they started another antihyperglycemic agent or insulin therapy, to make sure that we are isolating the true effect of the agent. These are observational data sources, so we adopted a broad range of diagnostic measures to ensure the study power. And first of all, to ensure the sufficient sample size, we included cohorts with at least 1,000 patients. To ensure covariate balance, we conducted propensity score stratification to achieve a standardized mean difference, SMD, of less than 15. As a proxy for statistical power, we used a minimum detectable risk ratio of less than 4. And to achieve empirical equipoise, we included the target comparator database combinations, where at least 25% of the patients had a preference score of between 0.3 and 0.7, meaning that the probability of the patient being started on that agent is between 30 to 70%. We also, to address the residual confounding, we conducted negative control calibration. And lastly, to check for hazard ratio proportionality assumption, we looked at the Kaplan-Meier plots. Here are the results. We included 1.5 million patients with type 2 diabetes and established cardiovascular disease from 10 different data sources and 4 countries, where US open claims, Optum data death, and Optum EHR contributed the most. 16% started SGLT2 inhibitors, 8% GLP-1 receptor agonists, 28% DPP-4 inhibitors, and 48% sulfonylureas. Over 1.4 million patient years of follow-up, we adopted 26,000 3-point MACE and 41,000 4-point MACE outcomes. So, to show one of the core diagnostics that we've done, here we are looking at the maximum standardized mean difference across all covariates for all 6 target comparator and 10 different data sources that we had. The blue dots show the maximum SMD before PSS stratification, and the orange one shows the maximum SMD after PSS stratification. The dashed line shows the cutoff of 0.15, which shows covariate balance if the maximum SMD is less than 0.15. And as you can see, the PSS stratification consistently achieved covariate balance across all data sources, across a majority of the data sources. So we ensured covariate balance. We also ensured empirical equipoise, and we addressed residual confounding. Here, we look at the meta-analytical calibrated hazard ratio estimates. On the y-axis, we see SGLT2 inhibitors, GLP-1 receptor agonists, DPP-4 inhibitors, and on the x-axis, we see GLP-1 receptor agonists, DPP-4 inhibitors, and sulfonylureas. The 6th plot shows the 6 different target comparator pairs, And for the sake of time, we just focus on the 3-point MACE and 4-point MACE comparisons, where if the effect estimate is on the left side of the dashed line, it favors the y-axis agent, and if it's on the right side, it favors the x-axis agent. So in the comparisons of SGLT2 inhibitors, we found that there was no difference between SGLT2 inhibitors and GLP-1 receptor agonists in terms of 3-point MACE and 4-point MACE, but SGLT2 inhibitors were superior to DPP-4 inhibitors and sulfonylureas. For the GLP-1 receptor agonist comparisons, we found that they are superior to DPP-4 inhibitors and sulfonylureas, and we also found that DPP-4 inhibitors are associated with a lower risk of 3-point MACE and 4-point MACE compared with sulfonylureas. As a sensitivity analysis, to make sure that none of these effects estimates are driven by one of the data sources, we conducted a leave one out meta-analysis, and we found that in more than 98% of all of these leave one out meta-analysis, the effect estimate remains in the 95% confidence interval of the original effect estimate, which shows robustness and is reassuring. So in conclusion, in our patients, we found that SGLT2 inhibitors and GLP-1 receptor analogs are not different in terms of cardiovascular outcomes, but they are superior to DPP-4 inhibitors, and DPP-4 inhibitors are superior to sulfonylureas. Thank you. I would like to thank you, and with that, I will hand it to my dear colleague and friend, Dr. Phyllis Thangaraj.
Thank you so much for having me. Today I'm going to be talking about a continuation of what Aline and Arya have talked about in an important LEGEND type 2 diabetes subgroup, which are patients with diabetes who take cardioprotective medications as first-line therapy for glucose control. So as Arya mentioned, the American Diabetes Association guidelines before 2022 suggested that anyone with type 2 diabetes and hyperglycemia should start with metformin as first-line antihyperglycemic therapy. And if this was not enough, should start as second-line DPP-4I inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, and sulfonylureas. Since then, we've had randomized clinical trials that have shown cardiovascular benefit, specifically when using GLP-1 receptor agonists and SGLT2 inhibitors as second line. This includes reduction in heart failure hospitalizations and reductions in cardiovascular and all-cause death. Because of these randomized clinical trials, since 2022, the American Diabetes Association has recommended for anyone with type 2 diabetes and established cardiovascular disease, they should start GLP-1 receptor agonists and SGLT2 inhibitors as first-line antihyperglycemic therapy. The question is, how successful will this guideline change be? By understanding baseline initiation trends of these cardioprotective antihyperglycemics as first-line therapy, we can have a sense of the contemporary landscape of implementing this guideline. So luckily, with the LEGEND Type 2 Diabetes Association, we have a multinational federated network, initially with 18 million type 2 diabetes patients, 17 databases, and across 8 countries, from data from 1992 to 2021. And so we can use this to answer this question about what are the baseline trends of this medication initiation. Specifically, when we look at first-line therapy, and we'll talk about the cohorts in the next slide, we have 3.3 million patients from 6 U.S. national databases, 4 U.S. healthcare systems, and 6 international databases. To understand better where this comes from, we look at the study cohort. Our cohort includes adults with type 2 diabetes and established cardiovascular disease and no prior antihyperglycemic therapy use, including metformin and insulin. In addition, we compare using mixed linear effective models with subgroups, such as those without cardiovascular disease and those with prior metformin use. We then look along a period of a year for exposure to these antihyperglycemic therapies as first line, including the DPP4Is, GLP-1 receptor agonists, SGLT2 inhibitors, and sulfonylureas. And we study the calendar year trends and calculate the annualized change for each of these medications over these calendar year trends. So one thing we wanted to look at, first of all, were for these antihyperglycemic therapy, what are the baseline trends that we see? When we look at females, we see that, or when we look at people with GLP-1 receptor agonists, the females in general make up the majority of the patients, and this is significant, with a median, we see the trends here, but a median proportion of above 50 to 60%. And with SGLT2s, we see significantly lower, around a median of 40% across all of the databases. When we look at age greater than 65, we see actually not much of a significant difference in the proportion of people when initiated on GLP-1 receptor agonists and SGLT2 inhibitors. But you can see a wide range because of the nature of our databases. But in general, the median was around 40% to 50%. Now, when we look at obesity, which is a key baseline factor because it has been shown, GLP-1 receptor agonists have been shown to treat obesity, we see, at least in the international databases, that there's a much smaller proportion in general of obese patients, 3 to 30% in those who were initiated on GLP-1 receptor agonists, 0 to 10% in those who were initiated on SGLT2 inhibitors. And in the US healthcare systems, we see a median of about a third of patients being initiated on GLP-1 receptor agonists, and actually more of like a quarter, the median for SGLT2 inhibitors. Okay. Oh. When we look at something like coronary artery disease, we don't see much of a difference in terms of overall effects. But for heart failure, we do see a significant increase in the use across all databases of SGLT2 inhibitors. So the people who are initiated on SGLT2 inhibitors, a significant increase in the proportion of those with heart failure compared to those with GLP receptor agonists. Now, looking at specifically the yearly trends of proportionate incidence use of GLP-1 receptor agonists as first line, here on the left side, as Aline had shown us, we are looking at specifically the population of diabetes patients with established cardiovascular disease over the years, and we look at proportionate incidence trend, meaning the proportionate incidence use when you look across the 4 different antihyperglycemic therapies. And when you calculate the slope of the increase, you see an annual rate of increase of 1.3 to 5.4% in US databases, and the lowest being from the VA, while the highest being from a national database, CCAE. In contrast, in the non-US databases, there's more of a stagnant increase over time, with an annual rate of increase of 0.3% to 0.8%. And the lowest being in China, with the highest being in Germany. When we contrast to SGLT2s as first line, I'm sorry, the two rates of increase are mixed here, but when you see there's actually a relatively higher increase rate, 2.1% to 12.9% in the US databases, with the lowest being Medicaid patients and the highest rate being from Stanford, compared to an annual rate of increase of 8.1 to 10.6% in the non-US databases, with the lowest slope being from SIADP, which is Spain, and the highest being in China. So now if we want to look specifically at the proportionate incidence use over time of these traditionally second-line antihypoglycemic therapies as first-line, we look at the graph that Aline had just shown us. And if you focus on the top, which are patients from 2018, and on the left side, we have those from the US, and on the right, we have those, from non-US databases. In the red, we have the proportion of people with DPP4I. In the blue, S-sulfonylureas, the yellow, GLP-1 receptor agonists, and the green, SGLT2 inhibitors. And one thing we could see in overall trends is that the US databases tended to use sulfonylureas more, significantly more, which is in the blue, while the non-US databases in the red tended to use the DPP4Is more. And over time, when you go down the axis, that's the two plots on the bottom, you see a significant increase in the cardioprotective medications. That's the yellow and the green, the GLP-1 receptor agonists and the SGLT2. In this case, the US databases had a significant increase over time, a higher significant increase over time of GLP-1 receptor agonists, while the non-US databases had a higher significant increase over time of SGLT2 inhibitors. Now when we look at the subpopulation of no CV risk versus CV risk, overall trends, we see obviously over time an increase in the cardioprotective use. So looking from top to bottom, we see an increase in both non-CV risk and CV risk of cardioprotective medications. However, in general, in the non-CV risk patients, we see a higher increase of GLP-1 receptor agonist use, while in the cardiovascular risk patients, we see an increase in the SGLT2 inhibitors. So overall, we see a cardioprotective antihyperglycemic therapies have increased in first line over time. And the rate of increase of SGLT2 inhibitors versus GLP-1 receptor agonists depended on US versus non-US databases and CVD versus non-CVD risk. And given what we see, especially with the increase in cardioprotective AHTs over time, this seems to bolster the idea of the contemporary landscape being ready and willing already, even before 2022, to comply with these guidelines. Furthermore, now we're interested in understanding, similarly, if these patients are getting these drugs as first-line antihyperglycemic therapy, is there a CV benefit now that they're not on metformin or insulin? And right now we're having an ongoing LEGEND type 2 diabetes comparative effectiveness study specifically answering this question, since we don't have any randomized clinical trials studying this. So thank you very much.
Thank you, Phyllis. I would like to invite Hannah Yang to continue our conversation. Thank you, Hannah.
Hi, everyone. My name is Hannah. I'm an internal medicine resident from the University of Calgary. I feel very grateful to be here and to have played a small part in this project. So today I'm going to be presenting our study looking at the risk of diabetic ketoacidosis with SGLT2s in the treatment of type 2 diabetes. Before we start, I also just wanted to extend a huge thank you to Dr. Mark Suchard for being the driving force in these studies, as well as our data partners that participated and lent their time and efforts, and finally to the broader LEGEND group for making these studies possible. So I'm going to start off by talking about diabetic ketoacidosis, or DKA. So this is a life-threatening complication in diabetes that is typically characterized by hyperglycemia, hyperketosis, and acidosis. Nationwide analyses using inpatient samples across the states has shown an increasing trend in DKA over time. And while this has traditionally been thought of as a complication seen in only type 1 diabetes, we're actually seeing an increasing number of patients with type 2 diabetes presenting with DKA. This represents a significant burden of disease reflected by admissions into ICU, prolonged hospital stays, and really prevention of DKA remains the crux of the problem. So this brings us to considering what role SGLT2 inhibitors might play. We think that there is a theoretical risk with these agents that might predispose some individuals in certain situations to be at higher risk of developing DKA. So I'm going to briefly review what that mechanism looks like. SGLT2 inhibitors act on the sodium-glucose co-transporters in the kidneys to increase the wasting of glucose in the urine. And by lowering the serum or blood levels of glucose, this tells our body to release less insulin and more glucagon to maintain homeostasis. And it is this increased glucagon to insulin ratio that stimulates the breakdown of fatty acids and leads to the formation of ketone bodies. Now, importantly, there's usually some sort of acute trigger that increases the presence of stress hormones and really emphasizes this side of the pathway to increase ketone body formation, which ultimately increases the risk of DKA. These acute triggers can be things such as starvation, surgeries, illnesses, anything like that. And despite this proposed mechanism of risk, the RCTs investigating this question have demonstrated mixed results. One of the major challenges is that because DKA is still a rare complication, it's quite challenging to obtain sufficient sample sizes that are adequately powered for analysis. So here we have just a brief table looking at the sample size and corresponding DKA events for the original clinical trial programs for these agents, as well as a meta-analysis of 39 RCTs, and then finally our LEGEND study on the bottom, just for a comparison of those numbers. Another limitation is that because of the intensive monitoring involved in these programs, it's quite difficult, pretty much impossible, to translate this into real-world medicine. So this is where observational studies can play a vital role. The benefit of using real-world data can offer us valuable insights into the safety and efficacy of these medications in clinical practice. So if we look at a recent meta-analysis of 14 cohort studies, we see an increased risk of DKA with SGLT2s compared to other antihyperglycemic agents. And another notable study that we wanted to compare to was conducted by Wang in 2019. And this was a large-scale, retrospective, federated database study that employed Odyssey's best practice population-level estimation methodology. And their methods also included a broad and narrow definition of type 2 diabetes, where the narrow definition was meant to exclude potentially missed or misdiagnosed type 1 diabetes who are already at higher risk of DKA. And they found an increased risk of DKA with SGLT2s compared to sulfonylureas using both definitions, in addition to an increased risk when compared to DPP4 inhibitors and GLP-1 receptor agonists using the broad definition. So now that we've reviewed some of the existing literature, I'm going to briefly discuss our study's goals. Our goal was to conduct the largest retrospective observational study to date using 10 real-world health data sources. And with the rigorous methodologies of the LEGEND initiative, we also wanted to provide an updated hazard risk estimate of DKA amongst the second-line agents. As each LEGEND study aims to fine-tune its cohort definitions, we'll next take a focus on how we defined our target cohort. Keeping in mind that I think our most updated cohort is our best attempt at a fair and realistic representation of what the clinician knows about the patient at the time of prescription. So for our methods, we used an active comparator and a user design to compare the second-line agents that we previously discussed. Our target cohort included those who were at least 18 years of age with a diagnosis of type 2 diabetes, and we excluded patients who had previously received insulin within the last 30 days or had previously been diagnosed with type 1 or autoimmune diabetes. We also excluded those who had previously been treated with any of the other second-line agents. And our primary outcome of interest was an inpatient or emergency visit for DKA. As the statistics have previously been reviewed, I'll summarize this quickly. So in brief, we use an on-treatment analysis to compare new users of each second-line agent, and to control for confounders within each comparison, we use large-scale propensity score stratification. To address residual study bias, we calibrated our results against an empirical null distribution. And to ensure reliability and generalizability within each data source, we performed several diagnostic tests while blinded to the HR estimates, and then only unblinded estimates from those comparisons that passed diagnostic testing. So moving on to our results, here we have a forest plot distribution showing the risk estimates between new user cohorts for each drug class combination. And in the bottom row in purple, we have our meta-analytic risk estimates. The grayed out entries show entries that didn't pass diagnostic testing, but we included it here for completeness sake. So overall, we found an increased risk of DKA with SGLT2s compared to any of the other second-line agents. And we did also note a lower risk with GLP-1 receptor agonists compared to DPP-4 inhibitors. In terms of how our results compare to the existing literature, direct comparison between observational studies is difficult, especially owing to how differently we define our cohorts. But if we were to compare to the meta-analysis done by Lee and the previous study done by Wang, we see some consistencies in the higher risk of DKA associated with SGLT2s. So here you can see an overlap in our meta-analytic 95% confidence intervals. With the exception, in our study, we saw a much higher risk of DKA with SGLT2s compared to GLP-1 receptor agonists. So in summary, our study finds an increased risk of DKA with SGLT2s compared to other second-line agents used in type 2 diabetes. The overall higher risk that we see in observational studies compared to clinical trials may reflect the challenges in monitoring and following up these patients who experience acute stressors or the other known precipitants of DKA. So in conclusion, the main takeaway is for clinicians to continue prioritizing guideline adherent practices and to really take a focus on patient education around sick day management and recognition of the early warning signs of DKA. That concludes my talk. Thank you.
Thank you, Hannah. Now we're going to have someone joining from the UK. We have Dr. Daniel Morales joining from University of Dundee.
Absolutely. And in our interconnected world, where connections don't happen quite as efficiently as we expect, it's going to be a minute or two to get that taken care of. So while we're doing that, I'd like to say I'm extraordinarily honored and impressed by this opportunity for these early career researchers to really blossom in terms of observational research and its integration with clinical care. So another round of applause for them. Daniel, the floor is yours. Almost yours.
Daniel, you should be able to hear us. Oh, there we go. We can.
Okay, so the topic of drug development is quite long, but non-clinical studies to be performed. And during the animal studies of GLP-1 receptor agonists, they were found to have effects on the thyroid gland, particularly in the development of thyroid cancers, especially medullary thyroid cancer. The slide here, the image here, basically shows some calcitonin, dose-dependent GLP-1 receptor agonist release of calcitonin through activation of the GLP-1 receptor. Now, calcitonin is an specific biomarker for the thyroid gland and C-cell number, and it's used in sort of clinical monitoring of thyroid disease and thyroid cancers as well. And medullary thyroid cancer was identified as an important potential risk in the risk minimization plan for GLP-1 receptor agonists upon approval. And this has led to a number of sort of planned prospective post-authorization safety studies that are being planned but not concluded as yet. But interestingly, despite the common concerns around thyroid tumors, this led to different regulatory action. So as we see here in some of the product information, the US FDA implemented warnings on the risk of thyroid C-cell tumors with GLP-1 receptor agonists, and also imposed contraindications in people with a personal or family history of medullary thyroid carcinoma and in people with a history of multiple endocrine neoplasia. Whilst on the other side of the pond, in Europe, there were no specific warnings or modifications for use. So last year, there was a European nested case control study published using French national data, demonstrating an association between GLP-1 receptor agonists and the development of thyroid cancer and also of medullary thyroid cancer. It was approximately a 1.6-fold increase and 1.8-fold increase, respectively, over a cumulative duration of 1 to 3 years of exposure. And this led to a regulatory safety signal being raised within Europe. And as part of that safety signal, there was a cumulative review of the available evidence. And this is perhaps an example of right evidence in the right place at the right time, because thyroid tumor was specified as an outcome as part of the LEGEND Type 2 Diabetes study design. And therefore, a report was summarized and submitted pre-publication to the EMA to be included as part of the totality of evidence and that cumulative review. I'm going to present just the meta-analytical estimates of the association between GLP-1 receptor agonists and the different other second-line agents in patients with type 2 diabetes mellitus. And these results use the same design that's already been presented earlier on in this plenary session. And despite the different databases, we saw consistently no association between GLP-1 receptor agonist exposure and the risk of thyroid tumor, which was the outcome specified in the LEGEND Type 2 Diabetes study, despite the different analytical approaches in terms of propensity matching or stratification. And here, this is the summary estimates of the intention to treat treatment strategy. We also saw consistent estimates with the on-treatment or the per protocol design as well. And this also aligned quite nicely with a subsequently published cohort study from South Korea showing no significant increased risk of thyroid cancer with exposure to GLP-1 receptor agonists. So the results of the safety signal in Europe were that at this point in time, the evidence was not sufficient to support a direct link between thyroid cancer and GLP-1 receptor agonist use, and no update to the product information was performed. That sounds great, but there are certainly some learnings that we observed. So first of all, thyroid tumors are very rare. And despite the federated analytical approach, only the US databases had estimates that passed cohort diagnostics, to be able to contribute to the meta-analysis. And this raises an important issue of generalizability of the evidence that we've been able to generate, and the importance of sample size, that despite the federated analysis, there are still some limitations here. The other interesting element
to consider is that the outcome specified in this analysis is one of thyroid tumor. This consists of both benign and malignant thyroid tumors. However, the regulatory focus was on thyroid cancer, in particular medullary thyroid cancer. This shows a slight difference between what is often of interest to decision makers versus also the biological plausibility, because the non-clinical studies showed increases in the incidence of thyroid adenomas, or the benign tumors, as well as thyroid cancers, if not to a much greater extent. And this has implications for phenotyping development and also the data quality aspects as well, and the granularity of data that can be captured within data sources, specifically if we wanted to study something as granular as medullary thyroid cancer. And here we just see the breakdown of the distribution of codes from open claims. And we see actually that malignant thyroid, neoplasm of the thyroid gland or thyroid cancer does constitute a significant proportion of this phenotype. But further work will be done to refine this as well for publication. Thank you. That concludes my talk, and I'll hand over back to the plenary session. Thank you.
Thank you, Daniel. Thank you, everyone. I would like to request another set of applause for the members of our panel. Now we would like to open the floor for the audience to ask some questions for our panelists. Please feel free.
In order to do this, there are a couple of microphones set around the room. I know it takes a little effort in the morning to get people out of their chairs and asking questions. So sort of my prerogative as an organizer, I'm gonna talk into the microphone, and I'm going to go first. With LEGEND hypertension, we've been able to impact clinical care, both in terms of initiations of thiazides versus ACE inhibitors, and our most recent comparison of chlorthalidone versus hydrochlorothiazide, which is already making itself into treatment guidelines, for example, through UpToDate. What are kind of, for the whole group, what are sort of the most important clinical findings that you guys have seen up to now? And what are sort of the steps that we need to take to get this into practice? Remember, there's a drink for everyone that answers a question.
Okay, well, I'll start. So, do you mean across, and I guess if we were to lump in LEGEND hypertension with T2DM, I think one of the most satisfying results I'd have to actually say is the chlorthalidone one, just because it has been such a persistent feature in guidelines, but when you give it to patients, they crump. And so our hypertensive guidelines has long been driven by randomized clinical trials, which reflect a certain amount of patient monitoring that is just very difficult to achieve in clinical practice. And it's been really satisfying to see a really well done set of observational evidence corroborate what I think clinicians have suspected when they try to use this drug for years. So that would certainly be, I would say, my favorite result of the LEGEND set so far.
Yeah, and I would like to add as well that all of these comparisons can be done in the setting of randomized clinical trials, which are the highest level of evidence that inform clinical practice. But not all of them are feasible in the real world because they are resource intensive, they are costly, and we can't feasibly conduct all of head-to-head comparisons in RCTs. So I think this is where Odyssey comes to the play, that it can play a major role in filling these knowledge gaps. And actually, so far, we have seen that some of the results of some of the trials that have been published have been reproduced with all of the state-of-the-art methodologies that we've been using in the LEGEND-T2DM network or Legend Hypertension network, which is reassuring that with this framework, we can predict the result of randomized clinical trials. So maybe we don't need to do all of them, and we may need to keep building the Odyssey community and gaining more participating centers to be available to produce more and more robust results.
Great, thank you. Please go
ahead. Thank you so much. My name is Samir. I have two questions. The first one is, you have done the study since 1992 until recent. So were you able to control for different changes? For example, there is some regulatory actions, or for some medication, there is some more utilization of some of these medication. You know, some medication withdrawn from the market, like the TZT, and shifting to other medication. So did you consider that in your comparison analysis? And the second question, I think you're planning to do a study for first user without metformin. So, because all guideline patients should start with metformin. So will you be able to find patient without using metformin? Thanks.
So from what I showed, we had found at least 3.3 million patients who were first-line initiated on these antihyperglycemic therapies and not metformin for whatever reason, but it was 3.3 million patients across the databases. And I think your questions are both very important. I think that's when we're building our study cohorts and the observational periods, and when we're doing these analyses of analyzing trends and comparative effectiveness, you have to define what your timeline is going to be. So for example, when I was looking at the annualized changes, we know that the benefits of SGLT2 inhibitors and guidelines really only came into play in 2016. And so that's kind of when I started my comparative analysis of the trends. And so you have to have that clinical intuition and understanding in mind when you're defining your observation. And of course, when you're saying this first line, it's also not a perfect analysis either, because we have a set observation time when we're seeing when the person is off metformin. Ideally, they were never on metformin before, but we're limited by the data we have and what we know.
And for the question about 1992 to 2021, actually a few data sets have included data from 1992, and we have data mostly from 2011, 2012 till 2021. And if some of the practices have changed so far, but with all the diagnostic measures that we adopted, we believe that if some patient or a cohort should not be included in the comparison, we excluded them from the final meta-analysis.
Thank you. We have one more question from the audience. Please go ahead.
Oh, well, congratulations on this, on the LEGEND type 2 diabetes studies. I remember when the hypertension one was presented, I was just blown away by the volume of evidence. And now you've shown again with another LEGEND study how powerful the observational research is. My question is that, you looked at different aspects of, medications for type 2 diabetes. And in some of them, I heard that SGLT2 inhibitors and GLP-1s are better than others, but then the SGLT2 ones cause diabetic ketoacidosis. So in the totality of things, what would you recommend somebody who's got type 2 diabetes and starting, a medication journey? Which drug comes out on top? Which class of drug comes out on top?
It's on.
It's on. Is it? Oh. I can start to take a stab at that question. I think based on all of the cardioprotective effects that we see with SGLT2s, I don't think necessarily our findings from our DKA study would negate that. Part of it definitely comes down to clinical intuition as well and looking at other risk factors that the patient has. For example, if they had DKA in the past, anything that would predispose them to it. So I think our study is just another puzzle piece to the bigger picture. And so if anything, it would support our current guidelines, but just really emphasize on prevention and recognizing what the risk factors are and providing education to those patients about what to look for and what to avoid.
I think that's also the wealth of the different choices we have. So you can personalize it for your patient, and with the preponderance of evidence, like Hannah just said, of the cardioprotective effects of GLP-1 receptor agonists and SGLT2 inhibitors, in someone with cardiovascular disease, it would make sense to start them. And that's where the guidelines are going. But if it doesn't work for them, they get DKA, you always have another option. So it's more like a wealth of choices, I think.
That's great. And then to the last questioner about will you find patients who have not started metformin? I remember one of the results from the treatment pathways study that George did was that in Japan, metformin was not a dominant first-line drug. So maybe in other countries, we could find those patients to add to this study. Thank you. Thank you for a wonderful and very informative study. Thank you.
Yeah,
That's a really good point.
Okay, thank you, everyone. If anyone, we don't have any other questions, should we move forward? Sure, yeah.
We have a networking reception. I know there are many more questions, but we're going to have a Q&A session.
Oh, yeah.
Yeah. There's a Q&A session not only on the clinical findings, but also in development of these large-scale observational studies and how it involves a whole community to accomplish that. From clinicians through to statisticians and informaticists and wonderful epidemiologists like Kevin. So I'm going to put you off.
So sorry, Kevin Haynes, Johnson & Johnson. So to take that last question from a patient level, but now to a payer and population level, how do you convince a large payer, like let's walk into Blue Cross Blue Shield of New Jersey this afternoon, or Independence Blue Cross or somebody, or Optum or something, how do we translate these results to then inform and promote those cardioprotective events over the metformin? Remember, metformin is nice and cheap. These other drugs are expensive, so from a PBM perspective, it looks like it's a big cost. But yet, if you can show them that this is the number of hospitalizations, which of course is a medical spend, that I will decrease. So how do we really translate these results into number needed to treat, number needed to harm, put them all in a benefit risk framework, both with the DKA results and with the efficacy results, so that you really have a coherent message to both the payers and the government organizations that will actually promote the use of these safe medications?
I'm going to start with a very short answer on that, and that requires an entire community, like the community that we have here, that will take more than just the comparative effectiveness information, combine it with utility, cost effectiveness, and integrate with regulators and providers. So I'm going to end up deferring that until our larger question and answer period, where we have all of those expertise. Right now, I want you all to enjoy a networking experience. There should be some treats outside, and don't forget that bio break. It's a really long day. Thank you.